My name is Greg Mantsios, and it's my privilege to welcome all of you to the CUNY School of Labor and Urban Studies. I want to thank our panelists, Baruch College, Basil Smikle, and Robert Pollin for being here with us today. They'll be introduced to you shortly. For those of you who are joining us for the first time, I want to introduce us to you. We've been around for over 35 years as the Murphy Institute for Worker Education and Labor Studies. And a year ago, we opened our doors for the very first time as the CUNY School of Labor and Urban Studies. It's the 25th and newest self-standing school in the CUNY system. And what makes us unique and stand out amongst those 25 units is that we are dedicated to public service and social justice. We have three main missions. One is to help prepare the next generation of labor and community leaders. And to fulfill that mission, we offer undergraduate and graduate courses and degrees and certificate programs that focus on workers and worker organizations on the one hand, and then on the other hand, focus on urban centers and the problems of poor working class communities. The second part of our mission is to provide opportunities for workers to achieve some kind of economic stability and mobility. And towards that end, we provide opportunities for workers to get training and educational experiences that help advance their careers in whatever field they're in. And finally, to serve the higher education needs of labor and the broader community. And in this regard, we focus on shaping public discourse and public policy through research, through publications, through civic engagement trainings, and through public programming like this one. I'm going to leave it to our moderator to frame the discussion. Moderating today is Basil Smikle. I should say Dr. Basil Smikle. Basil was awarded his PhD in politics and education from Columbia University just a few months ago. Basil has served as visiting distinguished lecturer here at the School of Labor and Urban Studies. Prior to joining SLU, he served as executive director for the New York State Democratic Party, and prior to that, he served as a senior aide to Hillary Clinton on her campaign and in her Senate office. He's a familiar face because he's a regular commentator for public policy and electoral politics and appears regularly on MSNBC, CNN, and other media outlets. He has a wealth of information. He's fair-minded. He's very balanced in his views. He's a great teacher and observer and commentator. On a personal level, I just want to say that he's been not only a colleague, but a friend, but a strong supporter of the school. Please join me in welcoming the newly minted Dr. Basil Smikle.
Let's get right into it. Barbara College is one of our panelists this morning. She is a practitioner on the faculty of the Marx School of Public and International Affairs at Baruch College here in New York. She's got over 40 years of experience as a nonprofit union and public agency manager, consultant, and administrator. Most recently, she served as Director of Strategic Policy and Planning for SEIU Local 32BJ, which provides benefits to 250,000 people living in 7 states, where she oversaw a substantial redesign effort dedicated to developing incentives for members to use and providers to offer. She's currently advising a number of clients on local health policy, health benefit design, and her writing is regularly featured in Urban Matters. Barbara College. Bob Pollin is a distinguished professor of economics and co-director of the Political Economy Research Institute at the University of Massachussetts Amherst. He's also the founder and president of the Pollin Energy and Retrofits, an Amherst-based green energy company operating throughout the United States. His books include The Living Wage, Building a Fair Economy, co-authored in 1998, Contours of Dissent, U.S. Economic Fractures in the Landscape of Global Austerity, an employment-targeted economic program for South Africa, and many, many more. He's Worked recently as a consultant for the U.S. Department of Energy, the International Labor Organization, the United Nations Industrial Development Organization, and numerous non-governmental organizations in several countries on various aspects of building high employment green economies. I do want to frame our conversation a little bit today. I was reading an article in The Intercept titled "Massachusetts Unions Vote to Vet Presidential Candidates on Medicare-For-All, Breaking with Labor's Top Brass." And it got me thinking that as incredibly popular as Medicare-For-All is, there's still some question about its efficacy. Should we do this? Should we not do it? And I wanted the program today to really talk through some of the concerns, the underlying assumptions, the pros and the cons. And I want to be specific that it is not an endorsement of any particular candidate's views. I don't want us to be an extension of the Democratic debate. There's one next week, I think. Isn't that right? And then if you've seen them, you see how spirited that debate has been when they get into discussions about healthcare. I don't want this to be a debate about specific candidates, but I do want it to be a lively discussion about, again, as I said, the underlying assumptions, the concerns, the benefits, and also the process. How do we move from what we're dealing with now to what we're trying to get to down the road? So I'd like to begin the presentations. Barbara.
I'm very excited about this discussion because it has forced me. I teach this stuff, and I teach it in 14 three-hour sessions. And today, I'm going to compress all that into 10 minutes. It's been a major challenge, but I appreciate actually the opportunity to do it, to think it through more than I had before, and to think about 10 minutes of salient points. Much of what I have to say you'll know, but I don't think many people know the history of Medicare, the original, the 1965 version, because health reform has consequences. And those consequences are in large measure what gave us the system we have today, the approaching $3.8 trillion system that does an inadequate job, costs too much, and is really, really difficult to change. So I'm going to start with a discussion of what happened in a little bit about Medicare, talk some about the system it created, the consequences of some of the deals that were made, and then end up with a couple of minutes of what I think makes the most sense for now. Take a look at this quote from JFK. And other than the characterization of this as a productive, progressive country, which I don't think anybody would say right now, this statement could have been uttered by almost any Democrat. There isn't a country in Western Europe that doesn't do what we're doing 50 years ago or 40 years ago, and not a single country that is not way ahead of us of this rich, productive, progressive country of ours. We are not suggesting something radical or new or violent. We're not suggesting that the government come between the doctor and his patient. We are suggesting that every other major, developed, intelligent country did for its people a generation ago. I think it's time the United States caught up. He made that statement at a rally in Madison Square Garden in 1963, one of 30 simultaneous rallies that was held around the country to promote Medicare. I'm sure you all know the history. This had been stalled since it wasn't included in the Social Security Act in 1935, had various iterations, and finally the time came, the Democrats believed in 1960, to do something which was clear to them needed to be done, and that is fill the gaps. Increasingly, people getting insurance through their employer. By 1960, 75% of the population had employer-based coverage, and excluded were the elderly and the poor, because they didn't have connections to an employer, and it was time to fix that. And Medicare is what they produced. Medicare and, as an afterthought, Medicaid. Two really salient points about Medicare. One is that it was born in part with a political deal between the Democratic administration and the American Hospital Association. The AHA owned and promoted Blue Cross. They had created Blue Cross as a way to finance their hospitals. And by 1960, the commercial insurance companies had taken over about half the market, which meant, and they paid fixed amounts, $100 a day. Blue Cross paid whatever you needed, whatever it cost is what we pay. And that was a deal the AHA wanted to promote, and that was a deal the Democrats thought was a good idea. Although originally in the bill, as the House passed it, prices were going to be regulated by the government. But in the conference committee between the Senate and the House, the Senate demanded, and the House agreed, that the prices would be set by the providers. That was one piece of the deal. The program that they created, Medicare, Part A and Part B, were modeled after private insurance. Part A after Blue Cross, Part B after Blue Shield. Blue Shield was owned by medical societies. They introduced the whole package, Medicaid, Medicare, et al., with an amendment to the Social Security Act. Section 1801 is the beginning of that amendment. Basically, it says the government will not ever regulate anything having to do with the practice of medicine or the provision of insurance. Just take a minute to read it. Of course, when you tell the providers that they can set the prices, they set the prices. And one of the consequences is lots and lots and lots of dollars started pouring into the system, public dollars as well as private dollars. Healthcare costs rate of change, rate of increase far exceeded even the cost of living. Even in the inflation 70s, healthcare led the way. So much so that Nixon actually established a wage and price council that froze healthcare reimbursement. So that's one consequence. In point of fact, the U.S. is public spending on healthcare is basically congruent with every other developed country. We spend about the same percentage of our gross national product. Our public spending is equal to Canada, Germany, the UK. What differentiates us is our private spending. So the private is the red. The public is the gray. So you can see the gray is sort of even. The private spending is way, way greater in the United States. This is a kind of an interesting chart. This says that in 1960, right before we created Medicare and Medicaid, we looked like the rest of the world. Our spending was about 5% of the gross national product. But with the enormous increase in the price paid for health care, we look very different by 2016. In fact, our health care expenditures, now approaching $3.8 trillion, are greater than the total gross domestic product of the UK, India, or France. And as Henry Aaron, not Hammering Hank, but Henry Aaron of Brookings, commented when he wrote about the failure of the Clinton plan, he said, imagine reforming the economy of France with one bill. Most of the money, I think you know this, but over half of the money goes to pay for labor. In the personal care part of the health system, which is about 2/3 of it, it's about 2/3 pays labor. Healthcare is a jobs engine. The system now employs 1 in 6 American workers. Nurses are the dominant profession. Everybody else kind of falls behind. And the professionals, particularly nurses, doctors, and senior therapists, their rate of increase in their wages has been double the rate of increase of the workers in the so-called support occupations, the lower paid occupations. So one of the consequences is we have an incredibly distorted system. This is a chart that shows maternal mortality. Maternal mortality should be rare. In the United States, it's increasing. We make a smaller investment in primary and preventive services than any of the other developed countries, less than half. but we spend a lot of money and do a lot of really expensive high-tech procedures. We have 4% of the world's population. We account for 2/3 of the world's heart transplants. Heart transplants, Medicare reimburses about $260,000 for a heart transplant. They pay $90 for a doctor visit. There's not much margin on a doctor visit. There's $100,000 on average margin on heart transplants. So what's wrong? Well, the first, and I'm just going to summarize now, serious reform comes with consequences. Among the consequences in our system is it costs too much, it doesn't provide what we need. And how did we get here? We got here in large measure by putting in charge the very system. We agreed to not regulate and then put the not regulated industry in charge. So what do we do about it? What's driving, I think, the discussion about healthcare right now is the sense that people have that my benefits aren't secure, that if I need services, I won't get it. We need to fix that, and there are ways to do that that are not included in disrupting the benefits of 320 million people. And we have to reform this system, we have to tame the beast. The beast that keeps growing, the industry. I think the beginning of taming the beast is beginning with reasonable price controls. I think it's the first step. Thank you very much.
I'm very happy to be here. I have a lot of connections with this institution and program, even though I've actually never set foot in it before. Number one, I was a columnist for New Labor Forum for, 7 years, 8 years. They worked me too hard, so I quit. But Paula was my editor, along with Steve Frazier. My good friend and co-author, Stephanie Luce, is a senior faculty member here. I think she's chair of the department right now. And she and I wrote 2 books together on living wages. I'm happy to be in her institution. I just also want to mention that Dinnie Gordon is here. Dinnie is an old friend, and her late husband, David Gordon, was my dissertation advisor and remains an inspiration. I probably never would have even gotten into this line of work if David hadn't instilled in me the idea that if somebody asks you to do something and it's an important question, then give it a try. And so in this case, I had no background in healthcare economics whatsoever, unlike the other speaker, until about 3 years ago when the National Nurses United leadership, Roseanne DeMoro, asked me to write a study for the proposal that they were advocating in California. So that was my first foray into doing work on healthcare. And from that, I kind of flowed right into doing a national study, which is the economic analysis of Medicare-For-All, that was tied to the Bernie Sanders proposal of 2017. He since has another 2019 proposal, as does Congresswoman Pramila Jayapal. I have consulted with the Sanders campaign. I have consulted with the Warren campaign and with Pramila Jayapal. So I'm kind of familiar with the kinds of, at least the debates that are going on among those groups. So as I see the political terrain, the 3 questions that seem to be coming up over and over again, including in the debate, is how in the world, number one, how in the world can you move 150 million people off their current employer-based private health care plan? That would be the first one. A second one, why would you move them if they like their plan? And then the third seems to me the biggest question that keeps coming up over and over again. Well, how in the world do you pay for Medicare for all? So given that I only have a very short amount of time initially, I will just try to answer number 3. And I think that would give us a framework for understanding 1 and 2 as well. Medicare for all, what is the purpose? And again, roughly, the numbers I'm going to give you are based on estimates of the 2017 Sanders bill, and I can tell you about differences between the 2019 bill, Jayapal bill, and so forth, but that's basically what I'm talking about. The 2 fundamental goals are to deliver high-quality health care for all U.S. residents, number one, and to do it in a way that actually controls costs and reduces costs. And the conclusion that I reached in the study is Medicare for All is able to accomplish both of those goals. Now, the first way through which this becomes a plausible kind of idea is simply by looking at what other countries do. A quote from Kennedy is quite relevant here. Other countries provide health care at roughly 9 to 11%, other advanced economies at roughly 9 to 11% of their GDP, roughly $4,000 to $6,000 per person, and they get better outcomes. We spend roughly 18% of GDP, and it's going up, and roughly $10,000 on average per person, and we get worse outcomes. So the easiest way to start thinking about how to restructure U.S. healthcare is basically look at what other countries are doing. Not that we would necessarily emulate exactly Canada, UK, France, Germany, but there are so many other models out there. And essentially, the research project that I undertook was drawing in ways that I thought were productive, constructive, on what the other countries are doing to accomplish better outcomes at much lower costs. First, on the question of the coverage and demand. So we're talking about universal good quality coverage. And we're talking about a program through which people will have no co-payment, no cost sharing whatsoever, no deductible. And what would be the result of that? Well, naturally, we would expect people to start using the healthcare system more because we have about 9% of the population right now that is uninsured. We have about another 26% of the population that is what we call underinsured, meaning they have health insurance, but when they have a healthcare problem, they face financial difficulties. They can't pay for what they need, and therefore they go without care. That's roughly 26% of the population. What we are talking about is a system whereby everybody has good access to the health care they need. And the question, and that they are not going to be discouraged by having to make any kind of co-payments, financial disincentive to get the health care they need. So the question is, okay, then how much is the system going to increase in terms of utilization? How much is demand going to go up? So, we go through this length. It's a 200-page study. But just to give you the result, what we did look at various research studies, including some of the critics of Medicare for All, such as Kenneth Thorpe at Emory University and Charles Playhouse, who did the study for the Mercatus Institute, the Koch brothers funded institute. Actually, my estimate as to the cost increase, the demand increase, is higher than both of them. Higher than Thorpe, higher than Playhouse. So I'm estimating cost increases would go up by 12%. Okay, Playhouse was at 11.3%. That's the Koch brothers finance study. So I think I have a high-end estimate. That's basically the way through which we conducted the study throughout, is to be conservative in all of our estimates. So we have 12% increase in utilization, but under Medicare for All, we estimate that we can get something like 19% savings relative to our existing system. And how do you get 19% savings relative to our existing system? Well, there are two big items and then some small. You can see them all listed. The two big ones are basically the savings through a dramatic simplification of administrative costs and reduction in profits and marketing, but administration. So claims processing, credentialing, and so forth, all of those things that take up a lot of time and that therefore that end up being at about 12% of system cost in the private system, as opposed to 2% of system costs, roughly speaking, for Medicare for All. So that's how the two big ones, those two constitute 15% of the 19% savings, and there are some other smaller ones. But basically, when you combine a 12% increase in utilization, if we increase our existing system by 12%, then we get a 19% savings. The net impact is that we run the system at about 9.5% less than what we're spending now, and everyone is covered. That's the bottom line. So what I generate, these are the results right now for health consumption expenditures, which is a subset of total health care. We're at about 3.2 trillion. We would go up to 3.6 trillion if we covered everybody decently. That would be the 12%. And then we contract through the 19% savings through administration and pharmaceutical pricing being the two drivers. And we're at a system that will cover everybody decently, I think a fair assessment, at 2.93 trillion, or a little less than 3 trillion. And that's basically what you're seeing in those bars. We go from 3.2 trillion to 2.93 trillion with everybody getting decent coverage. How do we pay for that? These are the exact numbers that you see, but I'm going to round it to make it all as simple as possible. So basically, if we say we have a $3 trillion system, and then basically we already have $2 trillion coming in. The existing Medicare, Medicaid, that what Barbara was talking about, VA, Defense Department, and some smaller programs, they are basically bringing in $2 trillion. We don't have to look for that money. We need to raise $1 trillion to cover the rest of the 2.93. There are various ways that you can raise $1 trillion, obviously. What we talked about is a system whereby we keep the focus on businesses contributing roughly 60% of all the funding. There's various ways we can tax businesses. One of the ways is a gross receipts tax. A gross receipts tax on like everything, all their receipts, a gross receipts tax at 1.8% for businesses would raise over $600 billion. So that means we still need $400 billion. So again, speaking in simple, rough terms, I have two sources there. One is a sales tax on non-necessities at 3.75%. That would also raise roughly $200 billion, and a wealth tax at 0.38%, less than 0.4%, also raises $200 billion. Again, those are the rough numbers, and that's basically it. You need to raise $1 trillion. You get $600 billion from a gross receipts tax from business. You get $200 billion from a sales tax on non-necessities, and you get $200 billion on from a wealth tax, period. Very simple. So this notion that it's so complicated that, how in the world are we going to pay for it? It's actually very simple. And it's basics. Of course, there's all kinds of details. What are the impacts? If you're running a system that is costing roughly 10% less than our existing system, that means everyone who's putting in money into healthcare is going to get, on average, 10% cut in their expenses. Now, it doesn't work out exactly that way, the way I designed it. But basically, the system is businesses are going to pay, the businesses that are covering workers now are going to get an 8% cut. So a business that's putting $1 million into healthcare is the next day when Medicare-For-All is implemented, gets a $920,000 bill and $80,000 savings. They're going to like that. That's good. It's good for businesses. Middle-sized businesses are a huge beneficiary of Medicare-For-All. Households, wealthy households are going to pay more, but they're actually right now paying nothing after you take account of the tax subsidies they get. The biggest beneficiaries are middle-income households. If you can see what middle-income households that are on the exchange, buying healthcare on the exchange, are going to get a 14% benefit relative to their income. That's $9,000. Their $9,000 in spending that they're spending now are going to go down to $900 that they're going to pay in the sales tax. Those are the actual numbers that you see there for low-income families, high-income, middle-income families, and you see the range for middle-income families of these savings, very substantial. So the biggest beneficiaries of Medicare for All financially are middle-income households and medium-sized businesses. Then what about the overall system? Basically, what I show finally here is the system costs as projected over the next 10 years by the CMS, the Medicare-Medicaid system, at $42 trillion over the next 10 years. My projection is a little less than $38 trillion, which means we will save $5.11 trillion over 10 years by implementing a system that delivers health care to everybody at lower costs. Thank you.
Thank you very much, Bob and Barbara. I'm going to ask a few questions based on the presentations and just to get the conversation going. But at some point, very soon, we'll open it up to all of you to ask questions as well. The first question I have is really for both of you. And it's in a way going back before we move forward. We are now under the Affordable Care Act. How does Medicare for All supplement, change, get rid of the Affordable Care Act? Are we building on it, or are we, to allude to something you said, creating a bill that basically starts everything over again?
I don't disagree with that general characterization, except I would put it a little more positively. As I said, our existing systems, Medicare, Medicaid, VA, defense, we've already got 2/3 of the money in the pot to run Medicare for All. We are building on the existing system. The ACA has important positive features in that it is certainly an attempt to deliver universal coverage. It did succeed in reducing the uninsured dramatically from like 17% to 9%. So in that sense, the Medicare for All is building on that achievement and deepening it and establishing a basis on which everybody is always covered.
What about the actual healthcare infrastructure? What will change under Medicare for All? Will there be more community-based health centers? Is it going to be less bureaucratic if you walk into a hospital under Medicare for All than you do now? How does it actually change the healthcare infrastructure?
It doesn't. What it changes is the payment system. And the payment system is very, very important. I don't want to argue that it isn't. It's very important. It changes two things. It changes the payment system, and it changes people's sense of security. And in fact, health insurance is really about two things. It's about the access to care, and it's about sleeping well at night. And Medicare for All is principally about the second. Very important fact about the second, sleeping well at night. And it enables people to feel secure that if they or a member of their family or a friend needs care, they'll be able to afford it. It doesn't say much about what that care will be or who will provide it or how those resources will be organized. Is that an answer to your question? Okay.
Bob, I'll ask you to respond to that, and then I have a follow-up question.
In terms of access to care, well, Barbara said it's a contribution to helping us sleep well at night, which sounds good to me. But the access to care, obviously, it's universal access to care without any barriers, without any kind of co-payments, without any kind of checking on whether you have insurance, whether you lost your job, and so forth, which is part of what helps you sleep at night. The infrastructure will change dramatically. All of these areas, contracting, claims processing, credentialing, payment validation, all of those are going to be dramatically simplified. That's a big part of the point. The cost of pharmaceuticals will change dramatically so that people will not have to make a decision as to whether they can keep taking the prescription drugs that they need, whether or not they can afford it. That will be a dramatic and positive change. So those things will change dramatically. In the bills, all of the bills that are out there, Sanders 1, Sanders 2, Jayapal, people have guaranteed access to their provider of choice. Now people say, oh, that'll never happen. Especially if you have the 12% increased demand. Well, how is anyone going to get to see their provider? Well, keep in mind that physicians now spend, according to different surveys, spend between, let's say, 15 to 25% of their time filling out forms in administration. And that will be also contracting dramatically, which will free them and give them actually more time to treat patients, which also means more billable hours. So those things are embedded in Medicare for All.
Stepping back from who pays the bills, I tried to talk about, and maybe not very successfully, why the bills are so high. The bills are so high because the prices are so high. The prices are so high because we pay providers, drug companies, more pharmaceutical, medical companies, hospitals, et cetera, far more than is paid elsewhere. Getting control of those prices is actually an essential piece of however we fix the financing. That's number one. Number two, I don't know if you know this, but Medicare claims are processed by private insurance companies. The government never set up a mechanism to process claims. It actually contracts that out, and that was part of the deal the AHA made with the Democrats in 1965, that Blue Cross would be the fiscal intermediary for Medicare, and it continues to be. In part, it's bid out every couple of years, and sometimes it's other private insurance companies, but private insurance companies pay the bills. The third point is, if we cut spending, and I agree that essentially we have to eventually do that, it means fewer jobs. The health system has been a jobs-generating machine. It produced jobs even in the depths of the Great Recession, when we were shedding millions of jobs every few months. The health system churned along, adding jobs. It's the only part of the economy, the only sector of the economy that added jobs has added jobs every single month since January 2008.
And so Bob, just to follow up on a point that you made earlier, why are some unions concerned about this? Why is there some pushback from some organized labor?
Well, first of all, I would never, ever presume to speak on behalf of unions in any case, but certainly not on this particular question, why they might be opposed. As I said, I was recruited into this by National Nurses United, and I've certainly worked with a lot of unions over many, many years. I mean, look at what happened with the GM strike right now. So GM initially, when they went on strike, they said, okay, we're going to pull your health care. Now they ended up backing off on that point. But what we can accomplish through Medicare for All, it's true that unions have fought to get good health care for their membership. And that is an important accomplishment, and I do not disparage it at all. That said, if that is already built into our social contract, then unions will have the ability to bargain more effectively. Their fallback position will be stronger. GM or anybody else is not going to be able to say, oh, you go on strike, now we're going to take away your health care. That will not be part of the discussion. And so that the unions will have the capacity to bargain more effectively over the other things that matter, wages and other conditions of work. That's my position. I can't say that I'm speaking for anybody, including, by the way, the National Nurses Union, though they have sponsored my work. That actually will be a very important accomplishment. Now, on top of that, keep in mind, businesses are going to see their costs lowered. And that therefore that will enable them to spend more money on paying workers decent wages. As we know, we have experienced wage stagnation in this country for 50 years. So this will be a tool through which unions will be able to bargain better. Jobs will be lost in healthcare administration. A lot of jobs will be lost. I estimate 1.8 million. We say 9% savings in administrative costs. The main way, some of it is we get rid of the profits. of the insurance companies. We get rid of their advertising. Yes, that's true. But let's face it, the number one way through which we achieve savings is by laying off people who work in healthcare administration and insurance companies and are on the administrative side of providers. And that's why in this study, we spend a lot of time proposing just transition policies. Actually, both in the Sanders bill and the Jayapal bill, there is provisions for that. They're not well worked out. But the amount, the budgeting of what I would call a decent just transition program is within range, 1 to 2% of the costs of the system. Now, and when you have a system that's $3 trillion, then 1 to 2% ends up being real money. So I think we have to focus on that. I've said it over and over again. It's just a reality. There will be jobs lost in those areas.
I have a family in the UK. My niece is in college there, and it's interesting that in all of her conversations about where she wanted to go, the concept of going where she gets the most financial aid never comes into the conversation, right? Both her parents are doctors and work for National Health Service. And they talk to me often about the pros and cons of the work that they do based on the system that they have. So as we talk about job loss, and I want to actually focus on how the jobs actually change. Under Medicare-For-All, do nurses and doctors and the staff become government workers at that point? How does that work if what we're talking about now is initially based on Blue Cross and Blue Shield, which was the agreement that they would be unregulated? How do the actual jobs, even if there are losses, how are they transformed under this plan, and is that going to be a source of political tension?
No, I mean, I think what Barbara said was right around the other structural features. I mean, hospitals will operate more or less as they operate. The payment system will change, but the ownership of the hospitals don't have to change. Doctors' offices, they operate more or less as they do now, except that when it comes time to getting their bills paid, instead of getting reimbursed from one private insurance, another private insurance, another private insurance, they would get their bills paid through the government.
When the National Health Service, the UK's National Health Service, was created in the first Labour government after the Second World War, a Minister of Health was a man by the name of Nye Bevan, had been a Welsh miner who was a hero of Labour. And the health service was created very rapidly in that first couple of years after the war. And in 1948, Bevan was asked by a reporter, how in the world did you get the doctors to cooperate? And he said, I wish I could do it with a Welsh accent, but I can't. He said, I filled their mouths with gold. In any case, I wanted to give you that quote. It's a wonderful quote. I agree with Bob. What's paid for and how much is paid for anything has an enormous effect on the way services are organized. Who the banker is actually doesn't really matter that much. One of the things that's happening in our system is that increasingly there are very, very, very few office-based, fee-for-service independent doctors. 50% of American doctors are now work in practices owned by hospitals, and 45 of the remaining 50%, 90% of them work in large groups. And that, I suspect, will continue.
Okay. Thank you. I'll take a couple of questions.
The RAND study suggested a net increase in jobs. Looking beyond just the healthcare sector, is there a overall system-wide net increase in jobs, just as, for example, when the tax question comes up, we can talk about this is a net increase in income for 95% of people. Is there maybe a parallel to be made there on the job side?
Nobody has said clearly we're talking about doing away with private insurance industry, so I just want to make that point. But you said that we could finance this plan merely by a wealth tax and a sales tax on luxuries.
Not luxuries, non-necessities.
Non-necessities. Well, I don't use non-necessities or luxuries, so are you saying that I will have no tax and be able to get Medicare for all?
Yes.
And there's an important difference between the two presentations, I think, which hasn't been explored enough, and that is, Bob, most of the savings come from reduced administration and pharmaceutical. So the proposal you're talking about doesn't address what Barbara says is in fact, the major difference in the U.S. system compared to systems in the rest of the world, and that is the prices. And that in fact administrative costs, don't explain the higher U.S. prices. It is a very powerful, in fact, massive industry, the size of the entire economy of France. When dealing with administrative costs doesn't deal with the economy the size of France.
Okay.
And so are you really, reforming the system?
If you want to respond to those three questions.
So net increase in jobs, I don't believe that. I mean, I wish I could say I believe that. I don't believe it. I think there could be some modest increase in jobs. I don't see any significant increase in jobs. I mean, yes, there will be lower costs for healthcare, and that will be beneficial to, again, I would say medium-sized businesses primarily. And they are the biggest source of jobs. They're lower capital intensity. So I think there would be some modest increase, but I don't think any significant increase. I don't think that will counterweigh the job losses that will occur through the elimination of the private health insurance industry. Those jobs in a single-payer system are redundant. That's a fact. On the costs, we can go back to my slide. This is what I came up with. If you can tell me why it's wrong, fair enough. 19.2% cost savings, of which 9% is through administrative restructuring. And those, by the way, are pretty conservative assumptions based on comparative system analysis in other countries and other statewide systems. And 5.9% pharmaceutical pricing. That comes from the fact that we pay roughly 50 to 60% more for the same drugs as other countries do, and we built in a 40% cost reduction. Okay, what about moving to uniform rates for all healthcare, for all physicians? So that's what I think you're addressing. I don't see the gigantic numbers. It's not nothing. It's 2.8% of system costs. And again, when you have a $3 trillion system, that's real money. But I don't see anything bigger than that. I know that the Mercatus Institute study, Playhouse, the one for the Koch brothers, they have a massive cost reduction through moving through Medicare rates. They said it would be 44% of system savings. I have it at 3%. We both can't be right. I obviously think I'm right, so that's my issue there. Now, on your overall point, Mark, my projection, running the economy, running at 2.93 trillion, we are still at 15.8% of GDP. We are still much higher than other countries. And yes, if we wanted to get to 11% to Germany's rate, the next thing would be to cut rates to providers. And yeah, because doctors make more. I got them down to Medicare rates, which is about 20% less than what you make from private rates. Medicaid rates, they're going to go up because they're less than Medicare. But anyway, 15.8% is a lot more than 11%. But to get a further squeeze down, you have to cut providers, and we don't cut providers any more than moving to Medicare rates.
I want to actually add a little bit of a complication to the discussion. Our system, our gigantic healthcare system, depends on underpaying substantial numbers of workers. Actually, it's a pretty important point. I mean, we pay home care workers, for example, on average $25,000 a year, considerably less, actually, than they get paid in Canada. We pay nurses' aides. These are clinical workers. We pay them less than a living wage. And there's a very compelling argument to be made for increasing the wages of the workers at the bottom of the system. We depend upon underpaying substantial numbers of people. And even just to shift a few of those dollars, a few of the RN, MD dollars, just another point about this. Over the last decade, the amount of money, the wages and benefits and salaries of doctors and nurses have increased about 80%. It's a huge increase. Double the rate of increase of workers called support workers, home care workers, medical assistants, et cetera, et cetera, et cetera. So we have an increasing inequality inside of our system where some workers are getting very, very well paid and some workers are getting very, very poorly paid. And actually that's a shift that needs to happen. It can't happen tomorrow. You can't actually tell a doctor who is currently earning $250,000 or a nurse who's earning $100,000, next year you're going to get $10,000 less because we're going to make sure the home care workers get a little bit more money. But over time, and I actually want to make this argument again, this is the work of a generation to fix this damn system, to go from a system that costs too much and delivers too little to one that costs a reasonable amount. We pay a lot, we're willing to pay a lot, and delivers what we need. That doesn't happen overnight. That's going to take time. And in the meantime, there are some urgent problems that need to be solved and can be solved and should be solved with a significant expenditure of public money. With the expenditure of public money comes the need for regulation. I mean, that's got to be the trade-off. If we're going to give them more money, they have to be willing to do things differently.
So small businesses right now do not pay for health care for their employees. Under this plan, under Medicare for All, I believe they would be required to pay for health care, which would cause a significant harm to those companies. I have a small business. If I had to pay for health care for employees, I would not be able to stay in business. I have a small geriatric care management business working with older adults and their families. And I work with home attendants. This is actually a statement that home attendants, to Barbara's point, are the key for keeping people healthy in the community. If we pay them more and give them better opportunities, and under Medicare for All, we could actually keep a wide swath of the population healthy and out of the hospital so that we don't put as much pressure on the system.
My name's Judy Sheridan-Gonzalez. I'm the president of the New York State Nurses Association and also an emergency room nurse for many, 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 many years. We talk about finances, but there's so many other issues and hidden costs of healthcare right now that I think, have you thought about including in this conversation? For example, the absence of universal health care brings people to the emergency room where I work and where I see this, where end-of-life care or critical care or intensive care, serious illness costs so much more than preventive care. I think often that's not factored into it. In addition, the clinical issues of the turnover of disoriented and alienated healthcare workers is incredible. It's very costly. That doesn't get factored in. The other issue of the costs that people have to incur for a variety of things that aren't even critical illness, but develop tumors as opposed to prevention and finding these things. It's not even end-of-life care. It's what you talked about heart transplants and the things that have to happen for people who have deteriorating illnesses. And then finally, the community issue that I think doesn't get folded into the debate, aside from the moral and ethical issues, but the community issue of recreating a healthcare system in which communities sort of care for one another, which you do see in other countries, and you certainly could see in a system in which people were getting their health care not simply at tertiary care centers, but in community-based centers where all the social determinants of health could be addressed in a variety of areas, just as the speaker before me spoke of. All these different community-based areas in which people with healthcare could also be addressed. I just wonder if you've thought of adding that into the debate, because those are things that really touch people very personally, and I think the way to get to universal healthcare, a Medicare for All system, is to touch every individual in a place that's near and dear to them where they've had those experiences. We have an incredible nursing shortage. We have a shortage of all healthcare workers, and while I don't know the figures that you know about where that transfer would take place, that is really underestimated, and I think what Barbara was talking about in terms of having a different payer system doesn't necessarily cure the quality of care. Quality of care is addressed by being able to produce standard of living for the lower paid workers and increasing the caregivers that are incredibly short. When I started nursing, I had 8 patients back in the early 70s, and half of them could make their own beds. Now we have almost as many patients, and in the ER, twice as many patients who are incredibly ill. So the level of care that people are receiving is so poor in all of our healthcare facilities. Those things really should be looked at, because people don't understand that when they go into a hospital, they're truly putting their life in danger. That's my personal opinion.
You mentioned that you realized that all these workers would be displaced in the private companies when they switched over. What happens to people who own stock in these companies that are going to be put out of business? Because a lot of these companies, people own stock in those medical companies who are middle-class people who have their life savings tied up in stock.
As was mentioned, this is going to be a fight of a generation. It's not going to happen overnight. People are usually very resistant to change. And with such, when you start looking at wages, as was mentioned before, how do you think this will impact recruitment of future doctors, future healthcare providers? And would we as a country ultimately wind up with severe shortages, and also as a result long waiting lists and waiting lines and the kind of service that is not immediate up on need? And also there's the whole aspect of our veteran system, which of course is not perfect at this point, but if you speak to many veterans, they value that network very dearly, and that would also be something that would be a drastic change if it were to be rolled into the one universal care, which is what we're proposing.
All right, lots of really interesting comments and questions. I want to just draw an analogy. After lots and lots of political organizing and agitation, the Sherman Antitrust Act was passed in 1890. And it was a response, basically, to the railroad monopolies. And it was a pretty potent piece of legislation, but it had actually very, very little impact. There was some breakups of the trust, most importantly in 1911 when Standard Oil was broken up. But it really wasn't until 24 years later, with the passage of the Clayton Act that created the Federal Trade Commission, that there was a mechanism to regulate the trust. That was 24 years in the making. And I actually think our campaign to make this system affordable, better, and more responsive might take that long. But it requires us to do the equivalent of the Sherman Antitrust Act. The Sherman Antitrust Act set out in 1890 the intent and the conclusion, which was that monopolies were bad and it was the responsibility of the government to break them up. And I think there's an analog in healthcare. We need to get to that point. We need to get there, and then we need to work piece by piece, year by year, to tame the monster that our health system has become. Think about this. Every dollar that goes into the system grows their political influence and power. And we need to start to contain that, and we need to make better deals.
I just want to first mention in the Jayapal bill of 2019, the House bill, as well as the Bernie Sanders bill of 2019, there is a quite extensive provision for long-term care. Actually, Congresswoman Jayapal asked me to research on that point. I agree that the home health care workers are poorly paid. And beyond that, we have most of the treatment for long-term care is unpaid. If at least these 2019 bills, if something like those were to become reality, I think it would also be transformative in terms of raising wages, work conditions, and providing important care for long-term treatment. I think that may be one of the most important contributions of the bill overall. Again, there's various ways to finance. If we say we need to get $1 trillion, you can come up with a lot of different tax approaches. In the one that I proposed with the gross receipts tax, there is a $1 million exemption for businesses that are under 1 million. So if you have a business with less than 1 million gross receipts, you wouldn't pay anything. That's how I designed it. It could be wrong, and I'm sure there'll be many, many other iterations from other people. But in that case, it would not impact small businesses. So on the various range of social determinants of health and the role of preventive care, well, first of all, there'd be a bigger budget for preventive care, and that it would incentivize preventive care. One of the features of, at least as I see the bills out there, is important contribution is global budgeting. Entities have X amount of dollars and they figure out how to spend based on past history. But when you're operating within the context of a global budget, and as you say, it saves money to invest in prevention, then they will invest in prevention. Because if they don't invest in prevention, they're going to run out of money to pay the doctors and nurses. So I think that will be an important feature. In terms of the nursing care in general, the surveys that we cite in our study, the RNs are spending 19 hours a week on administration. It won't go to zero, but it'll go close to zero. So their jobs will be less stressful. They will also have more time to treat patients, and that's, again, an important contribution. What about what happens to the health insurance companies and the pensions or the funds that people have invested in them? Yes, the private health insurance industries will be out of business. People will have to move whatever funds they have into other areas of the economy where you can make money. I think, I could make the same argument about the fossil fuel industry. It will be out of business. It won't be the first industry that goes out of business. I mean, look at the landline telephone industry is pretty much on its way out, and people have to figure out where to move their money. But what about the workers? Well, as I said, a lot of what we talk about in our study is just transition policies for the workers, and we recognize that a lot of their wealth is tied up in their pensions. And so actually the first feature that we emphasize in the just transition is the guarantee of pensions. And we actually, for those of you that really want to fall asleep easily, you can read, we spend a lot of time showing how much is invested in workers' pensions in the pension funds of the private insurance companies on the assumption that these companies are going to go out of business, and what would it take to guarantee the pensions. And it should be a part of the bill, that this has to be, when we talk about a just transition, it can't just be 2 lines in the bill. It has to include that the pensions that the workers have tied up in these companies are going to be guaranteed.
In a sense, we do have healthcare for all, in a sense that I can go to any emergency room and get assistance. And that's the most expensive healthcare. Could you give me a little history about why that is a federal law, and possibly why we should try to change that so that hospitals will not spend all this money, as this nurse said, in emergency rooms?
I'm a former attorney. I represented Taft-Hartley Health Funds when I was practicing law. I'm also a former elected official in Stamford, Connecticut, where I live now. The topic here is what should be the position of organized labor. An important part of that conversation is what is the position of the employers. Employers fall into 2 baskets in my experience. One is public sector employers, local governments, state governments are being crushed with structural costs, pension and health care costs. Where do they stand on the payment system for health care? And then the other question is the private sector. Where are the private sector employers? What are their current position? Because it has significant cost impacts for them as well.
Particularly in a political environment where we're talking about progressive politics and movement toward $15 minimum wage, paid family leave, how do all of these things kind of mesh together? Are we going to be making trade-offs, or can they all coexist? And then we'll take a last question.
I think the main reason we're probably having this forum this morning is the way that the topic of Medicare for All has bubbled up in the political context. So what is the politics around Medicare for All right now, and its so-called competitors, because in Congress there's a variety of bills forward that use Medicare as a basis. It's not just the Sanders bill, it's not just the Jayapal bill, there are other bills more modest in scope. It's sort of picking up on the theme that you just mentioned and the previous questioner just mentioned, like, where are the stakeholders at? How are we going to get Medicare for all, regardless of the policy conversation? Like, how does this happen? We have in New York public sector unions that are blocking progress on a universal health care bill in our state legislature. And that's a very strange dynamic to be witnessing.
I'm happy to answer the question on the history of the emergency room. And Bob, you have the rest. We got this because the newspapers, remember those print papers, were reporting on people literally dying in the streets. Let me say they are. That's still happening. So during the Reagan administration, 1986, the Congress passed a law that basically gave everybody the right to use an emergency room and required the emergency room to treat them if they had a serious condition. So that's the origin of it. Just as a little side note to that, it also created a really interesting program called Emergency Medicaid. And Emergency Medicaid pays the hospitals if they take care of undocumented people who are poor enough to qualify for Medicaid but don't actually qualify because they're not citizens. And in New York State, the hospitals in New York State collected $1 billion in emergency Medicaid money last year. So it's actually a fairly significant program. So the right to get emergency care is written into law. It was done during the Reagan administration in 1986, and it continues, although we know that there are lots and lots of people who don't get care when they're desperately ill. And the rest is for Bob.
So let me start with the private sector employers. They're going to like it, whether they think they are or not. They're going to save money. That's what they like. So this is going to be less expensive. You know, the small businesses, as I noted before, at least in my design, are exempt, so they're not going to face this burden. But the larger businesses that have been covering their workers are going to spend less money on health care. Now, also keep in mind that, as it is, private businesses, according to surveys, over half of private businesses shop for a new health care plan every year. They're looking at different private plans and they're comparing. So the notion that I like my health care plan, you don't have the same one. These things change frequently. 17% change every year. They won't have to do any of that. And what again, part of the business savings that we built in is the administrative costs that businesses now incur to health care. So that will go away. The public sector employers also will like having to spend less money. The system will cost less. So therefore, everyone gets some kind of saving. You know, again, if you average it out for the whole economy and everybody got the same saving, everyone would get 9.6% savings. It doesn't work the way I designed it, it doesn't work exactly that way. But anyway, that's the benefit. The politics, I can't claim to be the expert. I can tell you that I'm doing work as a resource person with two of the presidential candidates and Congresswoman Jayapal, but they don't actually ask me my opinion on politics. They just ask me the kinds of things that I've told you about. You probably have a much better sense of it than me. I mean, I did the work for the California Nurses Union, and it passed the Senate. I literally made a presentation, I think it was on May 30th, 2017. The next day, the Senate passed Medicare-For-All in the state, or not, single-payer health care in the state of California, but it was blocked by Jerry Brown. And Jerry, it so happens, is somebody I've known for a long time, and he just wasn't going to do it. And I talked to him about it. I said, well, why don't you read the study that I did, and you can see how it works. He just wasn't going to do it because the pressure obviously was extreme. I said, Jerry, you know, you would actually this would be a historic move if you did this. This would be your legacy. Well, that's okay. He said, my legacy will be on climate change. And that's, who knows? And he also said, let Gavin do it. That was Gavin Newsom, was the then lieutenant governor. He ran on Medicare or single payer for California. Now that he's in, somehow it's moved further down on his list of priorities. So again, I cannot claim any expertise on what will actually be the leverage point that moves the politics.
Thank you all very much for this incredible conversation.